I cannot share my screen while someone is sharing. Okay. Okay, can you see my screen?
Yes. Yeah.
Okay, thank you. So firstly, I'd like to thank the organizers for giving me this opportunity to give you an overview of this project that I just started recently, a collaborative project between Odivala Dilks and Sahai's labs. So this project aims to answer two specific questions. The first one being, does radiotherapy modulate tumor-associated vasculature and derived angiocrine signals that may contribute to forms of resistance in non-small cell lung cancer? And if so, can we target this radiation-induced vascular dysfunction to improve the responses to radiotherapy? So first, I'd like to give you a brief overview as well on the tumor vasculature and its multiple roles in cancer progression, so you can understand where we're coming from and where we want to go to. So as I'm sure you all know, inducing angiogenesis is one of the hallmarks of cancer development. And this has traditionally been attributed to its conduit role on delivering oxygen and nutrients to a growing tumor mass. And this angiogenesis is basically the production of newly formed vessels from pre-existing ones. However, despite this being the principal mode of blood vessel formation and blood vessel feeding to the tumor, this does mostly not occur in lung cancer, which mostly depends on what we call the vascular cooptions, which is a growth pattern in which the cancer cells preferably grow around the surrounding already existing vessels, because the lung is already a highly vascularized organ. And so in the past decade or so, the field has evolved to understand that tumor vasculature has a completely independent role beyond its conduit role, in which when the endothelium is activated, it starts to change. And this is called the angiocrine signal, which is basically a change in the expression of growth factors, receptors, and ligands in its membrane, and also on the secretion of growth factors, cytokines, and chemokines that all have an impact, an important impact on the surrounding tissues. And importantly, we and others have shown that this contributes to tumor invasiveness, growth, and also resistance to DNA damaging therapies. And Rebecca Drake, our new RadNet PhD student, will tell you a little bit about this story. And so we also know that radiotherapy induces vascular endothelial cell dysfunction and inflammation. And actually, cardiovascular diseases is one of the main toxicities caused by radiotherapy in cancer patients. And this comprises deterioration of vascular tone, blood hemostasis problems, inflammation, and edema that occur all at the site of the affected endothelium. And there's also some published evidence that chronic vascular inflammation in irradiated patients can be detected even years after they have received their treatment. So in the cardiovascular field, it is known that ionizing radiation in the vasculature induces double-stranded breaks, oxidative stress, or via the release of these damage-associated molecular patterns by dying cells, all lead to activation of specific signaling pathways in the endothelium, which lead to sterile inflammation. And this comprises of the release of pro-inflammatory cytokines and also the overexpression of adhesion molecules that all contribute to the attachment of immune cells and also tumor cells to the endothelial wall. And so the idea of this project is that we're trying to link together these two concepts of the radiation-induced vascular dysfunction and these angiocrine signals, and trying to understand if these have an impact on the responses of the tumor cells to radiotherapy, and also if this has an impact in other components of the tumor microenvironment that then indirectly will affect the responses to therapy. And so how we intend to answer these two questions. So firstly, I have been developing unifocal murine models of non-small cell lung cancer using these tumor cell lines that contain a mouse-Nice radiotracer reporter. So these cell lines have been created by Gilbert Fruith at King's, and basically they contain this sodium iodide importer, which upon giving the mice a radionuclide such as technetium-99, they will uptake these radionuclide and be detected by SPECT. And this is just an example, as you can see here, using having put the Lewis lung carcinoma cells in the flank of these mice, you can detect with high specificity and resolution the primary tumor. And there is some signal in the stomach, which is unspecific because the stomach usually uptakes this radionuclide as well. So we're trying to use this technology to try to, when we administer the tumor cell directly into the lung, to kind of monitor the progression of the tumor. However, using these tumor cell lines, at least with the Lewis lungs, they are very highly, rapidly progressing. And so to try to develop a more slow-growing tumor, and sorry, this is how histologically it looks like. So this is the left lung lobe where we administered the tumor cells 3.5 weeks after. We already have basically the whole left lung covered with the tumor foci, and we already have some lymph node metastasis and some metastasis to the other lung lobes as well. So to try to tackle the issue of these rapidly growing tumors, I have been developing as well using the KP lung models, so using the mice that carry a KRAS G12D mutation and the P53 sites flanked by FRT sites, which upon the administration of adenoflipase, these become activated to these P53 mutant tumors. And this is a much slower progressing tumors, developing over 12 to 24 weeks after the injections. So after we inject either the adenoflipase or the tumor cells directly into the left lung lobe, we monitor the tumor growth by SPECT or lung-gated micro-CT. And once the tumors are established, we then perform different radiotherapy regimes, trying to mimic what patients receive in the clinic as closely as possible in these preclinical mouse models. So we will try external beam radiotherapy, so applying a conventional schedule, doing 2 grays per fraction 5 days a week, and then a hypofractionated schedule, increasing the dosages with less fractions, and also doing stereotactic ablative radiotherapy. And this will be done in collaboration with Tammy Kalber and Rebecca Carter at UCL, using their SARP machine, which allows us to do image-guided ablative radiotherapy. And then we'll measure the outcomes in these models, either the resistance to the primary tumor, relapse and distant metastasis, and characterize what is happening to the vasculature and surrounding tissues. Then in vitro, we are establishing 2D and 3D co-cultures of murine and human endothelial cells with tumor cells to try to assess the radioprotective effect of the presence of the endothelial cells upon the tumor cells. And also Alex Lemarois from Sahai's lab is developing the lung slices so that we can look at the crosstalk of the lung vasculature and immune cells upon radiotherapy. And so this is an example of a video that I hope it plays out, where you can see the tumor cells in green and the epithelial lung cells in blue. And we can see the movement of the tumor cells, and already here, possibly through alveolar capillary. But obviously we'll need to stain for the vasculature to be able to see these interactions. So this is the kind of approach we're trying to use. And once we understand what is happening to the vasculature and how these possible angiocrine signals derived from the radiation-induced inflammation are affecting the responses to radiotherapy, we are trying to translate this as much as possible using endothelial cell-specific conjugated aptamers. So aptamers have a high affinity and specificity targeting cell type specific. And so these are single-stranded DNA, RNA, or peptide sequences that target cell surface receptors and deliver a specific cargo. And so in collaboration with Professor Julia Merrill from Munich, we are testing these EC-specific aptamers, and this is an example using a RNA VEGFR2 aptamer, which targets this receptor specifically in endothelial cells, which is linked to our target of interest, siRNA. So we have been shown that these work very specifically in vitro and with specificity, and we are now testing them in vivo in our preclinical models. And this is an approach that can be combined in the future with other further therapies, such as immunotherapy, for example. So I'd like to acknowledge everyone, especially CABS, for supporting me in my career development, and RadNet for giving me this opportunity. Everyone in CADLab and Eric as well, who has been also very supportive in this project, Anna Wilkins and Alex Lemaroy, and our external collaborators and internal QMUL collaborators, and our sources of funding. And I'll take any questions now.
Thank you, Rita, that's great. Yes, Tony.
Hi, it's Tony Ng from King's. There's a lot of literature on radiation effect on lymphatics, and clearly there's communication between the vasculature and the lymphatics. Do you think there's scope for you to expand on what you're doing in the radiation work you propose?
It's certainly something interesting that we can always have a look at. It's not on our initial plans, but if there's still time, I'm sure both Gabs and Eric would be interested in looking at these, at the role of lymphatics. It's a good suggestion. Thank you.
Thank you.
Hello. The pro-inflammatory signature that you have in the vasculature is very similar to what you see in senescent cells, so this senescence-associated secretory phenotype. I was wondering if you, I mean, I can see you've got Esostil as a collaborator, so maybe you've looked at it, but I was wondering if you'd looked at senescence in your models.
That's a very good question. And actually, a lot of work that has led to this project comes from another project that we've seen that chemotherapy in lung cancer, specifically cisplatin, leads to this endothelial, vascular endothelial senescence. So it's certainly something that we will obviously look at.
It would be really nice to take your tumor models and look at the INCATAC model where you can delete senescent cells, so you can selectively clear senescent cells and see what effect that has.
Yes, we already have the mice.
Did she pay you to ask that question?
Thank you, Rita, that was great. We have to move on now. Thank you so much.